Hello, my name is Simon Wan. I'm a resident from the University of Montreal. I want to show you a teaching method that Dr. Matthew Cecchini and I have been doing during my month of elective and thoracic pathology. So because of the COVID crisis, case volume is down in surgical pathology. So this method allows a supplement to the regular caseload in order also to reinforce learning concepts. It's more practical based. So this is an exercise here, a Google form that Dr. Cecchini sent me. So first, I have these linked YouTube videos about UIP, about NSIP. So I can click on those and review those. So I did that earlier. And I also have this high yield non-neoplastic lung pathology review. So that will be super helpful. And I really like this little touch here, which is a review article from Surgical Pathology Clinics about idiopathic interstitial pneumonias. So I can review that and refer to that while I'm doing the homework. Now, my favorite part of the exercise is the following. I can click on a link here on Path Presenter to a digital slide, whole slide image with no patient information, completely anonymous. And let's appreciate the architecture here. This is obviously not a healthy lung. We have maybe some normal lung parenchyma here. All this looks like fibrosis. These large spaces that are subpleural. I wonder if that's maybe microscopic honeycomb change. They're all stacked up upon one another. Maybe a bit of that bronchial metaplasia. Now, I heard that UIP is supposed to be spatially and temporally heterogeneous, so I'm going to try to find some fibroblast. Oh, this one is good. Fibroblastic focus here. I'll take a screenshot of that, the exercise. And I think this is good for honeycomb change. I'll take a screenshot of that here. There we go. Now, the first question was, what is the best diagnosis? Well, when I was looking at the YouTube video, it looked kind of similar to the case there, spatially temporarily heterogeneous. I think this is UIP. I'll upload the photo of a fibroblastic focus just to show that, I think I identified the right spot. And then microscopic honeycomb change, the screenshot I took earlier. Now, these questions here, these are more general questions just to make sure I kind of understand the differences between the entities. Which one is temporally and spatially heterogeneous? That's UIP. Now, more uniform would be NSIP, which is a bit of a misnomer. Then the airway-centered multinucleate giant cells, poorly-formed granulomas, CHP, so chronic hypersensitivity pneumonia. Now, match the disease to the radiology. Okay, that's a bit more tricky. I mean, I'm in pathology, but it's important to correlate with radiology, definitely. So let's have a look. Upper lobe, I think, was the UIP, if I am correct. Oh no, UIP would be lower lobe predominant. Then upper lobe would be the NSIP, I think. Then ground glass, CHP. All right, so I'm ready. I'm going to submit this to Dr. Cecchini and see what he thinks.
Great. So thanks for joining and thanks for reviewing the case. And so maybe we can go over this first case that we have here. And so maybe you can start with kind of describing your findings at low power.
So at low power, this looked like a very patchy process. There was some normal lung parenchyma around here, and then these more fibrosed septae. Then these large cystic spaces that maybe seemed like they were overstacked and more located in the subpleural area.
Good job. Yeah, so definitely a subpleural distribution to this case.
And then the last,
like very heterogeneous in terms of its look.
And then there were also these fibroblastic foci, like these loose fibroblasts.
Good job. And I think there's actually a really nice one often at the interface down if you move to the bottom left.
Okay.
So I think there's one. Yeah.
Small one here.
Yeah, I think there's one more if you go zoom out a little bit and move to your kind of right a little bit. Yeah, so I think there's actually two right there. So if you zoom in here and just hold your screen there, I think I can actually annotate these here for you.
Okay.
So I think there's a nice fibroblastic focus right there. So, sorry. And then there's nice fibroblastic focus over here as well. But yeah, so there's a nice fibroblastic focus there. And so you can see it's kind of this loose proliferation of these fibroblasts that have a kind of a paler appearance on the H&E.
Yeah.
But yeah, and I reviewed the images that you submitted as part of the Google document, and you're exactly right in terms of areas of fibroblastic foci. And then as you showed it previously, there's areas of microscopic honeycomb change there as well. And I reviewed your image for that as well, and it was great.
Okay, awesome.
And then in terms of the descriptions of the different cases, did you have any questions about those? In terms of like matching the description with the type of interstitial lung disease?
I think so from what I understand, the CHP was more airway centered. This one was more subpleural.
Yeah.
I also heard these can sometimes be a bit of an overlap, but this one looked a bit more classic UIP.
Yeah. And how would an NSIP case look?
So I read that NSIP is a bit of a misnomer, and that really it looks quite more homogeneous. So this homogeneous thickening with can be similar to infiltrate in the septa or simply collagen.
Yeah, so the NSIP, you're right, it does have a much more monotonous look to it. It's very homogeneous. The septa are kind of uniformly expanded by kind of a fibrotic process, and that would be a classic case for an NSIP. Whereas this is very heterogeneous, both temporally and spatially, as you pointed out.
Mm-hmm.
Perfect. And then in terms of radiology, I know it's a bit challenging because we often don't get exposed to a lot of different radiology, but it can be really helpful in these cases, comparing the morphology with the radiology. So that's why I included it there.
Okay.
So you're exactly right in terms of UIP. The UIP cases tend to be lower lobe predominant, kind of a basilar reticulations and fibrosis, and they really have like prominent honeycomb change.
Okay.
The chronic HP is actually the one that's upper lobe predominant. And then it's the one that has the air trapping to it, which makes sense because it really has that airway-centered fibrosis, right?
Mm-hmm.
And then the non-specific interstitial fibrosis tends to have ground glass and areas of reticulation. And then that tends to have a little bit of subpleural sparing. But the radiology is actually best at diagnosing the UIP cases, and really they're looking for that presence of that microscopic honeycomb change. Many of these cases are actually diagnosed solely on radiology, and so only the cases are actually indeterminate based on radiology that typically come for biopsy.
Oh, okay, I see.
So I think you did a great job with these cases. Did you have any other questions about usual interstitial pneumonia?
I guess these must be, with random sampling, these must be really difficult to diagnose on a biopsy, for example. If it's a like needle biopsy, it's an kind of incidental finding.
Yeah, it's a challenging diagnosis. These are typically diagnosed on larger surgical wedge biopsies, which is what this is a case of.
Yeah.
There can be a patchy process, and so the ideal place to take a section from is actually at the interface from the fibrotic and the uninvolved lung. And so that's where it can be really challenging to diagnose, especially if they just get end-stage lung. And so they actually don't want to biopsy the worst part. You really want that interface between normal and abnormal lung, which allows you to see some preserved lung and those fibroblastic foci. They're really nice to make the diagnosis.
Okay. That's what
Sorry, do you know the classic presentation of these cases? Like what would be the demographics for what you would expect?
So I think for UIP, it was mostly men over 50 years of age.
Yeah, even a little bit older, like typically in their 60s, 60, 65 is the typical.
Yeah. NSIP was younger.
Yeah, it can be younger, yeah.
30s, 40s.
Yeah, or a little bit older than that as well, but kind of within that range. And then in terms of chronic HP, what are some potential exposures that patients could have?
So I think there were several things. I jotted down a few, like different pneumoconioses, like bird fancier's lung, any dust, a lot of occupational exposures or farmer's lung. Yeah,
that's exactly right. Yeah, so it's like typically birds, farmers, things like that. And there's a long questionnaires that patients usually have to go through to kind of identify potential exposures. And sometimes it can be actually quite challenging to find the exposure.
Yeah.
So I think you did a great job, and I think hopefully you learned something about some interstitial lung disease here, and we'll keep going with other cases. And it's great to keep learning together, even if we're because of COVID stuck at home. But yeah.
Yeah, at least I see you're by the beach, so you're
Yeah, exactly.
Weather.
And you're checking out the lovely Golden Gate Bridge, it looks like.
Exactly.
Yeah.
Thank you so much.
Yeah, thanks. Have a great day.